Hello and welcome to another Move with the Doc. I'm Dr. Roopa Shah, board certified family physician and health and wellness coach. So you guys know the drill. Just feel free to move, stretch, maybe go for a walk on this kind of chilly October morning if you'd like, just to get a little bit of sunshine. But we're going to talk about some women's health issues today, specifically menopause and pelvic health. This is an area that I am kind of excited to talk about because it's really getting a lot of buzz recently, and for some good reason. There's many women struggling with the symptoms of perimenopause and menopause, and these symptoms typically begin about 10 years prior to actual menopause. And remember, menopause is usually around the age of 50. So if we think about it, women are starting to have these symptoms in their 40s and even mid 30s, mid to late 30s, some of these symptoms can start. So I think it's a really good topic. It's very timely, and things are changing. And really, one of the things we're going to touch on today, one of the things I really want to deep dive into is hormone replacement therapy. So that's kind of going to be a little bit of the focus of this talk. So perimenopause. What is perimenopause? There's always a little confusion about the terminology we use. Perimenopause refers to the time in a woman's life when the ovaries start decreasing the amount of estrogen they produce. This causes the periods to become a little irregular, erratic. They can become heavier, more clots, things like that. It's also responsible for a whole host of other symptoms, including irregular periods, skipped or missed periods. One of the first signs that we will actually start to see, and I'll see this in my patients a lot, is the cycles themselves will start to shorten. So instead of 28-day cycles, we'll start seeing 26-day cycles. Your period will come every 26 days. So that's one of the first signs. We can see changes in mood, irritability, depression, more anxiety, more panic attacks, hot flashes. We all know this one. Vaginal dryness. Yes, this comes a little bit later, but it does come. Low libido, change in sex drive, difficulty controlling your weight. This isn't in your head. This actually also happens. Insomnia, trouble staying asleep, early morning wakenings. That's another symptom. Difficulty concentrating, memory issues, and joint aches and pains. So a lot of different symptoms. And maybe you're listening to this thinking, gosh, I have a lot of these. If you do, and you're in the perimenopause, talk to your physician. Now, remember, perimenopause, like I said, can last almost a decade. You are not considered in menopause until you have gone a full year, a full 12 months without a period. Okay, so it's worth it when these changes start happening to maybe mark it on a calendar when your periods are, because they're going to get erratic and you're going to forget. So mark it on your phone, in your calendar, when your last period was. After you've gone a full year without a period, any bleeding, and I really want to stress this point, I think most women might know this, any bleeding after that 1 year mark is considered abnormal, even if it's just a day of spotting. It's really best to let your physician know if you have any what we call post-menopausal bleeding, because sometimes that's the first and only sign of uterine cancer. So you really want to stay attuned to that and just let your doctor know. So the number one question that I've been getting lately in my practice from my female patients is regarding all those symptoms I just talked about, because they want to know, what can I do to feel better? Okay, what can I do to make those symptoms better? All those hot flashes, the memory, the sleep, the joint pains, all of that. So what I really wanted to deep dive into today was kind of what's been on everyone's mind lately, which is hormone replacement therapy, or otherwise referred to as HRT, okay? My reference that I used for this talk generally, almost exclusively, is the North American Menopause Society. Yes, there is one. It's called NAMS, N-A-M-S, and their position paper on HRT. It's very comprehensive. Anyone can actually look it up and use it. It is good. It is in lay people's terms mostly, so you can understand the majority of it. It's very detailed, clearly laid out, and it really outlines well the risks and the benefits of hormone replacement therapy, or HRT. So let's start with just a quick bit of history. Why all this buzz recently? Well, there was a study done in the 90s that looked at HRT, and this was the Women's Health Initiative. It was the largest randomized controlled trial to date on hormone replacement therapy, and it was women ages 50 to 79. Those results had a lot of impact, okay? And the upshot was that HRT caused a lot of cardiovascular events and possibly breast cancer, okay? But as we do a look back at that study, we kind of look at what maybe some of the flaws were. One was that they only used oral estrogen in the trial. They only used one formulation of estrogen, which is a form called conjugated equine estrogen at 0.625 milligrams. They only used one progesterone, medroxyprogesterone acetate, at 2.5 milligrams. And they had limited enrollment of women with what we call vasomotor symptoms who were ages 60 and younger, and didn't have enough participants who were within the 10-year mark from the onset of perimenopause. And that's really the group of women that we're trying to target when we talk about HRT, women who are in that kind of 10 years around menopause, okay? So let's fast forward to present day. The results are now known to be potentially a little less relevant. And the thought is that the risks of HRT may have been a bit overestimated, or I hate to use the word exaggerated, but a little overestimated. So there are different formulations of estrogen that are used. I'm not going to get into them all, into those details. The main thing to know is that if you're using, or if you're interested in using hormone replacement therapy and you still have a uterus, okay, you have to take a progestogen, okay, or progesterone, but I'll call it, for the sake of this talk, a progestogen with your estrogen. So you have to take those two things together, because taking what we call chronic unopposed estrogen, okay, has an effect on the lining of your uterus, and it increases the risk of endometrial hyperplasia and endometrial cancer. So you cannot take estrogen orally alone, okay? So women with a uterus have to take a progesterone with their estrogen, okay? Dosing. The goal when we're using HRT is you want to use, and this, goes for a lot of things, but you want to use the lowest effective dose of systemic, that means oral, estrogen therapy to treat your symptoms. You don't want to go big. This is not where you go big. You start small and you start incrementally. And again, you do that with a progestogen if you have a uterus. Just real brief, what are the different routes of hormone replacement therapy? Because we're not just talking oral. One of the biggest reasons women take hormone replacement therapy, and this I see in my practice too, the biggest symptom women are trying to treat are their vasomotor symptoms. That's what we call it, kind of in fancy terms, but basically this as hot flashes. So you can take an oral estrogen, you can use a transdermal patch, you can use a gel, and you can use a vaginal ring. So there's different formulations of estrogens. It seems that both the oral tablet and the patches are very effective for hot flashes. There are not to date any great clinical trials that look at the risk of heart attack, stroke, breast cancer, or blood clots with the oral versus the patch. And with the different doses, they just haven't done it. You would think that study has been done, but it has not been done. And so a lot of this data is extrapolated, and we're trying to, researchers, scientists, physicians are trying to sort through this to make some good recommendations. It seems that the patch and the vaginal formulations are more advantageous. They basically, what they do is, when you take something orally, you have to metabolize that through your liver. When we use the patch or a vaginal cream, it bypasses what we call first pass metabolism, and it bypasses the liver. So it's theoretically better for you, but still a little bit unclear if they're truly safer in terms of, again, blood clots, breast cancer, cardiovascular events. And when I talk about cardiovascular events, we're talking about heart attack and stroke. Okay, so that's when I say cardiovascular events, that's what I'm referring to in this talk. So brief word on safety, and I'll get to it kind of at the tail end again. There was a meta-analysis of studies in which participants older than age 60 that showed that hormone replacement therapy in those women over the age of 60 was associated with a small increased risk of coronary events, blood clots, stroke, breast cancer, and gallbladder disease. There's been some observational studies. Again, these aren't those randomized clinical trials. These are observational studies, so they're not the best, but they have not shown an increased risk of blood clots with the patch. Okay, so sometimes the patch is sort of our preferred go-to because there's some thought that maybe we don't see as much of that. But basically, the upshot of it is we need better studies looking at the dosing of the progesterone, estrogen. We need studies looking at the oral formulation versus the patch. We just need more clinical trials on this topic. But overall, hormone replacement therapy is associated with a rare increased risk of gallbladder disease, stroke, clots, and a potentially a very small increased risk of breast cancer. And I'll get to that at the very end again. Women who use estrogen alone without the progesterone, let's say they didn't have a uterus, then it seemed that breast cancer and Alzheimer's dementia was actually reduced. So they looked at that in the Women's Health Initiative. Women on the combined HRT didn't seem to have any differences in breast cancer mortality. That just means how many women actually died of breast cancer. So again, a mixed bag, but it does seem like in certain age groups, the risk was a little bit lower. Okay, let's move on to kind of just a quick point I want to make. Who is somebody who cannot, so if you're listening to this and you have these following things, you cannot take HRT. Who are the people that cannot take hormone replacement therapy? Well, number one, if you have unexplained vaginal bleeding, can't take it. If you have liver disease, you can't take it. If you've had, there's little caveats to this, but if you've had a prior estrogen sensitive cancer, including breast cancer, you cannot take hormone replacement therapy. If you've had a prior heart attack, stroke, blood clot, known heart disease, you shouldn't take HRT. And if you have a personal or family history of clotting disorders, don't take it. Okay, so we got that out of the way. Quick, what are some side effects of hormone replacement therapy? Once you start taking, what are you going to notice? Well, you're getting extra estrogen and progesterone, nausea, you're going to get bloating potentially some weight gain in some women, fluid retention, mood swings, headaches, breast tenderness, some of those things, if we remember when we took like birth control pills, very similar types of symptoms. I wanted to touch on bioidentical hormones. This is a buzzword and we hear it a lot. So a lot of people talk about, I want bioidentical hormones and then think that somehow they're safer and they're somehow better. The term is really misleading though, because there are both bioidentical FDA, like government approved bioidentical hormones like estradiol, estrone, medroxyprogesterone. And these are the ones that are regulated. They're regulated for purity and efficacy, okay? In contrast, I think when most people are talking about, I want to do bioidentical, they're talking about compounded bioidentical hormones. And that means they're prepared by a compounding pharmacist, and they combine multiple hormones, estradiol, estrone, estriol, DHEA, testosterone, progesterone, and they kind of put it all together in this, like, oftentimes a compounded cream. It can even be subdermal implants. I've seen pellets. I've seen troches. And that we're kind of wading into this, not so approved kind of world, okay? Or I would say non-standard world of hormone replacement. So a lot of times too, these folks, when they're compounding, will also base their therapy on the basis of blood, salivary, or urine hormone levels, okay? That's also considered unreliable because the differences in hormone pharmacokinetics, absorption, the way that they vary in the morning and the evening, and there's a lot of individual variability. So we typically do not like doing blood or hormone testing. And so a lot of women come in, I want my hormones tested. And it's a difficult discussion to say, this is rarely needed. It's not really useful, to guide therapy. But a lot of times compounders will require or request this and try to put together some sort of mixture that they think might be in your best interest. So that's all I'll say about that. But just know that we also have FDA-approved bioidentical hormones. So, okay, let's move into kind of the meat of the talk too, which is really probably what you're all wondering is like, should I take it? What are the symptoms that I want to treat? Or when should I be asking my physician if I should be taking it? So let's talk about the symptoms. The big one, and the one that I see probably in 70–80% of my women are hot flashes, right? That's the one I spoke about. And we call those vasomotor symptoms. It's just a fancy word. It just means hot flashes. But this is the biggest reason women want to go on hormone replacement therapy. They affect your sleep quality. They can cause irritability. It's difficult to concentrate when you're having hot flashes, and just overall a very reduced quality of life with hot flashes. Hormone replacement therapy decreased the weekly frequency of hot flashes by about 75%. No other medication, no other alternative therapy provided more relief. So this is really where HRT shines. And it really didn't matter in the studies they looked at whether it was oral or a patch. Okay, it seemed like it helps. So it helps with hot flashes. Okay, so that's the bottom line. Insomnia. Sleep disturbances are another really common symptom that I see, very common in perimenopause and very common even after menopause. They can be associated also with hot flashes and decreased quality of life. Also, we know poor sleep leads to mood problems, memory problems, even metabolic syndrome, meaning problems controlling your weight, obesity, and even increased cardiovascular risk. So sleep is important. Hormone replacement therapy with low dose estrogen and or progesterone may improve chronic insomnia. And again, this is all from the position paper from the North American Menopause Society. So it also, they looked at transdermal estrogen therapy, the patch. When I say transdermal, it just means that patch that goes, on your arm or your back. Transdermal estrogen therapy may benefit sleep in perimenopausal women, even if they didn't have hot flashes. So a lot of times those two things will go together, right? You have hot flashes, which affects your sleep. So it's kind of like the chicken or the egg. But even in women who just had insomnia issues without hot flashes, it seemed that HRT was a bit helpful. Moving on, genitourinary syndrome. Kind of a fancy word, but basically this refers to the changes women notice in menopause and perimenopause, changes to the labia, the vagina, the urethra, and the bladder. So this can include vaginal dryness, which we call atrophic vaginitis. You can get genital like dryness, burning with urination, during intercourse, like decreased lubrication, more irritation, and also urinary symptoms, urinary burning, recurrent urinary tract infections. That's a really common thing I see in postmenopausal women. So for these symptoms, vaginal estrogen is very much the choice. If this is the only symptom you have, it's excellent. This could be a cream. It could even be a tablet or the ring. They all contain some form of estrogen, right? Estradiol. And this tends to work really well. When we use it vaginally, you don't have to add the progesterone to it though, okay? Because it's the vaginal. So again, you don't have to add that piece of it. If you have a history of breast cancer, you need to speak to your physician. You can potentially with caution, but you would have to speak to your oncologist to make sure this was an appropriate treatment. Sexual function. Oral hormone replacement therapy and low-dose vaginal estrogen did provide relief for some of those vaginal symptoms we just talked about, and may help with that, what we talked about, like decrease that lubrication. So it does help with increasing lubrication, blood flow in the vagina, and even some sensation potentially in the vaginal tissue as we age. So it did not, though, and I repeat, it did not help with the libido. So if you're looking, like I've noticed my libido is low and I want to try it, studies didn't really bear that out. It helps with, like I said, lubrication, blood flow, those types of things. If you want to try for the libido, the patch seemed to be preferred versus the oral treatment, because the oral HRT basically could bind up what we call bioavailable testosterone. So the patch in this case, just for the libido issue, was the preferred choice. Moving on, osteoporosis, another fun thing we as women have to deal with, but menopause is associated with an increase in what we call bone resorption and the risk of osteoporosis. In the Women's Health Initiative, women who are 50 to 79, HRT, hormone replacement therapy, did increase lumbar spine and hip bone density and reduce the fracture risk. So that's kind of interesting. HRT does seem to improve bone mineral density as long as you continue therapy, but it's important to note this is not considered a treatment for osteoporosis. So it is not FDA approved to treat osteoporosis. There's other treatments that you'll have to look into for that. But women who are younger than 60 and within 10 years of that menopause age, it seems that oral hormone replacement therapy could be a therapy to consider to protect against bone loss. If you have premature menopause, this is women who maybe had to have their ovaries out really young for certain other medical conditions, hormone therapy or birth control pills may be a good idea to prevent bone density loss and reduce that fracture risk as well. Moving on to joint pain. This is, like, as I mentioned, another one of those symptoms. We feel a little bit more achy, creaky as we kind of go through that perimenopause. Estrogen was found to bind to receptors on the joint tissue. So that I learned. I didn't know that. And it does seem to protect what we call the biomechanical structure, and it seems to maintain overall joint health. But that whole mechanism of how it does so is not truly well understood yet. So the exact effect of estrogen on osteoarthritis is a little bit blurry still. We don't know that. But in women the women that they looked at in the Women's Health Initiative, women who were on HRT did say they had less joint pain and less joint stiffness compared to the women on the placebo, in the placebo group. So for what that's worth. Quick other points. I know we're running out of time, so don't want to keep this too long, but there's just so much. Sarcopenia. This refers to muscle loss, okay? So we know aging and frailty is associated with falls and death, even sometimes sarcopenia, that muscle loss and osteoporosis are related to aging and estrogen depletion. And we see this during the menopause transition. Some studies have shown a possible effect of HRT when combined. Okay, so this is key. So when they looked at HRT combined with exercise, okay, not just by itself, but with exercise, it did prevent the loss of muscle mass, strength, and performance, but was not shown in clinical trials. So again, you have to take some of this information with a grain of salt, because until you have a good quality clinical study, you can't say, oh, this proves this, okay? But in some of these preclinical studies, these women reported less symptoms. Gallbladder disease, risk of gallstones, cholecystitis, cholecystectomy, meaning getting your gallbladder taken out, was increased with hormone replacement therapy. So this is a risk people take. The risk might be lower with the patch than with the oral replacement, but again, was not confirmed with those randomized clinical trials that we like to see, but might be a slightly lower risk with the patch. They also looked at metabolic syndrome, diabetes. The women who received combined HRT in the Women's Health Initiative, this also kind of blew my mind. They had a statistically significant 19% reduction in the incidence of type 2 diabetes. So It seems that HRT does reduce some components of the metabolic syndrome, and the incidence of type 2 diabetes was decreased by 30% in another meta-analysis too. So it seems the HRT reduces the diagnosis of new onset diabetes, but it's not for the treatment of diabetes, okay? So it's just more of a preventative potentially. HRT could be used in women who have diabetes, type 2 diabetes, because it might be beneficial with their blood sugar or glycemic control, and when also used for menopause management. So we're not saying if you have diabetes, you should take our HRT. No. But if you have diabetes and you're suffering from some menopausal symptoms, you would want to talk to your physician about that. There was one study that looked at if hormone replacement therapy could help reduce that abdominal fat, that little pooch we all put on in the front, and weight gain. It looked like maybe it decreased that, but it was a very small effect. And again, I think the research is just not there to prove that. Moods and depression. This was interesting for perimenopausal women. Perimenopausal, okay, so before you hit menopause, there was evidence that estrogen therapy improved depressive symptoms similar to taking an antidepressant. This actually applied to women who were, remember we talked about the hot flashes, they can also make you irritable and depressed. They looked at women who just had depressive symptoms without the hot flashes, and it also seemed to be effective. So there might be something there. It is not effective for treating depressive symptoms in women who are postmenopausal. So they just looked at different ages, and that's kind of what the study bore out. So there seems to be a little window of opportunity in perimenopause, and that kind of mild depressive symptoms where HRT might be of benefit. There's some evidence that estrogen does enhance mood and improves well-being in non-depressed postmenopausal women, but again, it's not for the treatment of depression, okay? So I thought that was interesting. Okay, so, and I know we're short on time here, but let's switch gears because I think I gave you a good overall, I think, of symptoms you might want to use it for, but let's talk about some of the risks, right? Because we don't want to take something if it's going to cause us downstream other effects, right? So I think it's really important for all women to discuss with their physician, very specifically, their own unique health history to see if they're really a candidate for hormone replacement therapy. Because if you have certain health conditions, risk factors, you may not choose to try this, okay? And I mentioned some of those earlier, and there's maybe even more things that you'd want to talk to your physician about. But in the interest of time, I just want to talk about two kind of main risks that we hear associated with HRT, and that's cardiovascular disease and breast cancer. And those are some of the biggest things right now too we're hearing about. Cardiovascular disease. For healthy symptomatic women younger than age 60 who are within 10 years of menopause, there seems to be a favorable effect on heart disease. But again, this has to be balanced out with the small but rare increased risk of breast cancer, blood clots, and stroke, okay? So when thinking if this is right for you, again, you have to take into consider your personal history, your family history of cardiovascular disease, family history of strokes and clots and breast cancer and all of that. It's got to be the total picture. Starting hormonal therapy in postmenopausal women had no effect on what they called coronary artery calcification. So they tried to look at these secondary markers of heart disease, and they really couldn't find anything. The other thing they found was that women who started hormone therapy older than age 60, because sometimes I'll get older women too come in and asking, but if women who started hormone replacement older than 60, or if they were more than 10 years out from menopause, they were actually at a higher absolute risk for heart disease, blood clots, and stroke than women who started it earlier in menopause. Breast cancer, this is kind of the interesting thing too. The risk of breast cancer related to hormone therapy actually seems to be low. They estimated it's a very rare occurrence, less than one additional case per 1,000 women when used for 5 years with a conjugated estrogen plus progesterone together. So what we call combined HRT. So to put that into perspective, that risk is similar to the modifiable risk factors such as having 2 daily alcoholic drinks, being obese, and low physical activity. So just to put into perspective, again, why was that risk a little bit overblown? Because that's really what it amounts to potentially. 2 alcoholic drinks, being obese, and low physical activity potentially carries the same risk of increased breast cancer as hormone replacement therapy. Again, the effect on hormone therapy, the effect of hormone therapy on breast cancer risk really depends on, again, the type of hormone, the dose, the duration, and your own individual health. So I hope, I'm going to kind of leave it there, but I hope we covered some of the main indications that you want to use hormone therapy, some of the benefits you would get health-wise, some of the risks associated with it. And if you're interested, then again, I just really recommend you talk to your physician or your gynecologist to see if it's the right decision for you. Because again, based on your health history, it's really going to be a matter of a very unique decision for you. Just because, if your friends are taking it or so-and-so's taking it, that's not going to apply to everybody. So I hope that was helpful. Enjoy the rest of your day, and we'll see you next time.